The next year will be helpful for you.
Hello, good evening.
Hello, good evening.
Hello.
Hello.
Can I request everyone to please go on mute?
Hello.
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 Just a minute.
Hello.
Good evening, everyone. Thank you for joining the session. I'm thrilled to welcome you all for today's informative webinar on approach to pleural effusion in OPD and IPD. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the evening, Dr. Sohail Mohammed. Dr. Sohail is MBBS MD DNB Respiratory Medicine. Dr. Sohail is an accomplished respiratory medicine specialist and academician, currently serving as assistant professor at Al Amin Medical College, a university rank holder in MD Respiratory Medicine from Rajiv Gandhi University of Health Science. He has also earned top honors, including first prize in the 34th Purview quiz conducted by CREST. He previously served as assistant professor at Kanachur Institute of Medical Sciences, Mangalore, and is an active contributor to medical education as a CME speaker and postgraduate presentation moderator. Dr. Sohail's work reflects a strong commitment to teaching, research, and advancing respiratory healthcare. Over to you, Dr. Sohail.
Hi, and thank you, Shabnam. Thank you for the wonderful words. Thank you. Am I audible?
Yes, Dr. Sohail, you are audible.
Yeah. And everyone can see my video?
Yes, video is also visible.
Okay. So, should I start?
Yeah, please.
I request everybody to turn on.
नहीं पीछा तो कब तक चलते पीछा निकालेंगे अच्छा लगता है गाड़ी में ऐसे
Other tents are also there, but it is the first gate that is
Okay. Everybody can see my screen?
Yes, doctor, the screen is visible.
Okay, thank you. So, good evening, everybody. I am Dr. Sohail Mohammed, MBBS in Respiratory Medicine, working as a consultant pulmonologist. Today's live webinar is on the topic APD, Pleural Effusion. In this live webinar, I'm going to cover a case which we are going to diagnose and treat, along with the theoretical part of the pleural effusions, and ending the webinar with the MCQs. So stay tuned. Let us begin with the webinar. What is the case? So here is Mr. X, a middle-aged male, presenting complaints of shortness of breath, left-sided chest pain, which is pleuritic type. We'll see what is pleuritic type in the subsequent slides. He also had a cough with minimal expectoration and left fever in 3 weeks. So all these symptoms are of duration of 3 weeks. He also complains of loss of weight and appetite. He is a smoker. He does not have any known comorbidities like type 2 diabetes mellitus or systemic hypertension, and no significant past medical or surgical history.
Sorry to interrupt you, Dr. Sohail, but the voice is breaking. The voice is not clear, actually.
Okay.
It's very low, very low.
Hi.
Yes, thank you. Now it's audible.
Now is it fine?
Yeah, it's totally fine.
Okay. I'll continue.
Yes, please. Yes, please.
Okay. Thank you. So let's proceed to the examination. So by seeing the chief complaints, that is the shortness of breath, left-sided chest pain, cough with minimal expectoration, and low-grade fever, let us go towards the examination part. He was conscious oriented. He does not have any pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. His vitals were tachycardia with pulse rate of 108, saturation was normal, BP was also normal, and slight tachypnea with a 22 cycles per minute of respiratory rate. On inspection, it was found to be a decreased chest expansion on the left side. Palpation, tactile vocal fremitus was reduced over left infrascapular, infraaxillary, and mammary area. And percussion was showing stony dullness on percussion in the same areas with reduced vocal fremitus and breath sounds over the left side. So the entire pathology is affecting the left side, that is infrascapular, infraaxillary, and mammary area as per the examination finding. So what we can do next? Can I see the chats? Okay, so you can interact. What we can do next? Anybody?
HRCT.
HRCT. Anything else? Because we are still in OPD. We are still, patient is sitting in front of us. Oh, ECG is done already within normal.
Get a chest X-ray.
Yes. So we can go for chest X-ray. Okay. And chest X-ray is showing.
Left side pleural effusion. First of any angle is.
Yes. So this is the chest X-ray finding. The chest X-ray is showing left-sided homogeneous opacity. Can see here with a curved line. Okay, and this is a homogeneous opacity, and you can see the right costophrenic and cardiophrenic angle is clearly seen, but here they are obscured. Correct?
We call that the meniscocine.
Yes, and we can see the intercostal space here. They are equal, and here you can see they are widened. Also, there are bilateral infiltrates in the lung. Okay. So probable diagnosis is left-sided moderate pleural effusion under evaluation. So we are still under evaluation process. So this is the first step of evaluation where ECG is done because left-sided chest pain, and second thing is chest X-ray. Chest X-ray shows evident finding suggestive of moderate pleural effusion on the left side, which has to be evaluated. Now coming to the theoretical part, the anatomy of the pleura and the pleural space. So you can see the lungs are covered by two layers of the pleura. The one is parietal pleura and the second is visceral pleura. And the layers, there is a potential space called pleural space. And pleura is nothing but a serous membrane, two layers, visceral and parietal layer. Can anybody tell me which layer of the pleura is pain sensitive?
The parietal.
Parietal.
Parietal. Very good. Parietal pleura is having sensory nerve endings, so it is pain sensitive. So whenever we are doing pleural fluid aspiration, the patient complains of pain is because of parietal pleura piercing. And potential space between these two layers is called pleural space. And this pleural space is not empty. It contains a thin layer of fluid, which is approximately around 5 to 15 ml on one side of the hemithorax. And it acts like a lubricant, where the parietal pleura and the visceral pleura, they slide over each other during the respiratory movement. And pleural fluid approximately production is 0.01 ml per kg per hour. So if you take a 60 kg person and for 24 hours, it comes around 15 ml and absorption is 20 times more than that of the production. So if you take a 60 kg person, it will come around 280 ml per day. So it is just an approximately value, which is the studies are showing. And these two layers are lined by a single layer of mesothelial cell, which are the flat cells. So by definition, you can see the pleural effusion is the accumulation of abnormally excessive fluid in the pleural cavity, either by increased production or decreased absorption. So in this pleural space, there is already existing normal fluid, which is up to 5 to 15 ml. And what we see in the pleural effusion is abnormally excess fluid, which can be either due to increased production or decreased absorption. So coming to the etiology of the pleural effusion is broadly classified into two types. The first is transudative and the second is exudative. What do you mean by transudative effusion? So transudative effusions, the etiology of these transudative effusions they are usually bilateral because they are of systemic causes. So first cause is, the most common is congestive heart failure, followed by cirrhosis of liver, nephrotic syndrome where the renal system is affected, hypothyroidism, it causes myxedema. Along with that, there will be bilateral pleural effusion and hypoalbuminemia. Okay. So these are the few common causes of transudative effusion, which are of systemic causes and they are having bilateral effusion. Exudative causes include any pleural effusion associated with the pneumonia. We have seen community acquired pneumonia with small effusion. Okay, or patient who are having lung abscess with small effusion, that is called as parapneumonic effusion. That is the most commonest in exudative effusion. And these effusions are usually unilateral. The first cause is infection, where we have bacterial causes, and tuberculosis is common in India. Empyema is nothing but a type of pleural effusion where there is a collection of pus in the pleural cavity. Fungal and parasitic causes are also there. In malignancy, we see the most common is adenocarcinoma of the lung, which is presenting with the pleural effusion. Mediastinal malignancies like lymphomas, which usually involves the lymph nodes. Pleural malignancies like malignant mesothelioma, and also the metastasis, the secondaries from the gastrointestinal tract like stomach or intestine, or from the bone, that is osteosarcoma, can also present with the pleural nodules and pleural effusion. From the gastrointestinal tract, we have common causes pancreatitis, which presents with left-sided recurrent massive effusion. Hepatic or splenic abscess, because of the reactionary phenomena, they can cause right and left abscess respectively. Esophageal carcinoma or rupture again causes left-sided effusion. Among the connective tissue diseases, we have rheumatoid arthritis, systemic lupus erythematosus, and Sjogren syndrome. Please remember that connective tissue diseases are the only exudative cause which are presenting with the bilateral effusion. Otherwise, bilateral effusions are more commonly transudative. If it is exudative, more likely the chance is connective tissue disease. From the gynecology, we have Meeks syndrome and pseudo-Meeks syndrome. We'll see what are those in subsequent slides. From the cardiac, we have post-COPG, that is Dressler syndrome and pericarditis. Pulmonary embolism can also present with the pleural effusion, and certain drugs which are not very common but rare, they can also cause pleural effusion. Among them is nitrofurantoin, amiodarone, and dantrolene. So let us discuss about the hemothorax. Can anybody tell what is hemothorax?
Blood in pleural cavity.
Blood in the pleural cavity.
Yes. So blood in the pleural cavity is called hemothorax. But when we see the microbiological diagnosis, the fluid analysis diagnosis, it is the presence of blood in the pleural space with pleural fluid, hematocrit, more than 50% of the peripheral blood. Sometimes what happens is when we are aspirating the pleural fluid, there can be a traumatic tap. So in that thing, what happens? Small drops of blood get mixed with the pleural fluid and it looks like a blood tinge, hemorrhagic. So we have to do pleural fluid hematocrit more than 50% of the peripheral blood. Yes, definitely it is a hemothorax. So certain common causes are trauma to the chest. It can be blunt trauma or penetrating trauma, which can occur in a road traffic accident. And post-surgical bleed, any cardiothoracic surgeries, post-surgical bleed or iatrogenic. Can you tell where we can see iatrogenic hemothorax? ICD, okay, good. But ICD insertion, we don't have to worry because if it happens also, it can drain off. Any other iatrogenic cause? Anybody? In ICUs, when you see the, yes, central line, very good. Central line, especially when you are going with the subclavian vessels, in that case, there may be chance that when you damage the vessel, it can go into hemothorax. Can anybody tell what is chylothorax?
Pus in the pleural cavity.
Sorry?
Pus.
Pus in the pleural cavity is empyema.
Chyle or
Yes, the chyle, the lymphatic structure, that is chyle. The chyle which is present in the pleural cavity is called chylothorax. So it is accumulation of chyle, which is a lymphatic fluid which is rich in triglycerides. Please remember this word triglycerides. I'll tell you why in subsequent slides. Okay, so common causes of these are thoracic duct, which is our major vessel which carries the lymph from body to the upper part. And then we have certain mediastinal lymph node malignancies called lymphomas. And these chylothorax are usually painless and afebrile because the chyle itself contains rich lymphocytes and higher inflammatory markers. So less likely they get infection. So, but there are certain chances that uncommon chances are there that may get secondarily infected, and that time we can see fever or pleuritic chest pain. Can anybody tell what is Meeks syndrome? It is a
effusion secondary to ovarian CA.
ovarian CA. You are partially correct. Can anybody correct him? Okay, so what he told is correct. It is a effusion which is secondary to, yeah, left. Okay. So it is a effusion which is secondary to the abdominopelvic organ, especially the benign ovarian tumor, especially the benign solid ovarian tumor, like we have fibromas, thecomas, granulosal cell tumor. They present with the ascites first, and it is not left side, right side is more common because the diaphragmatic, the defects, the channels which are connecting the peritoneum to pleura are more broader on the right side. So right side is first, left side happens later, but more commonly on the right side. And when we see the pleural fluid CA125 level, it can be elevated, but it is very non-specific. The diagnosis is entirely clinical and imaging based. So let us discuss pathophysiology. Consider this as a pleural space. Okay, everybody can see the arrow mark, the cursor which I am moving.
Yes.
Okay, so this is a pleural space. We have a parietal pleura and the visceral pleura. So whenever you see a small pipe, inside that there are protein, that is our blood vessel, and that protein is retaining the fluid inside the tube. That is what we call it as oncotic pressure. And there is a hydrostatic pressure due to the flow of the fluid that is pushing the fluid outside the vessel. That is called hydrostatic pressure. So for the fluid to go from inside the vessel to outside, we need very high hydrostatic pressure, which is pushing the fluid outside, or the pressure which is retaining the fluid inside should be low. That is, the oncotic pressure is low. Then the fluid will be going outside. So there are two important mechanisms. The one is increased hydrostatic pressure. Second is reduced oncotic pressure. After this, there are other mechanisms that the lymphatic drainage is blocked. When the pleural fluid is, the draining part is blocked, then there will be excess accumulation of the fluid in the pleural space. So increased hydrostatic pressure that pushes the fluid into the pleural space, which happens in heart failure because of the back pressure into the lungs. The pressure inside the pleural pulmonary capillaries will be more. Then oncotic pressure happens when there is a loss of protein. From where the protein will be lost, either it is lost through the renal system or it is less produced from the liver failure. And then in cases of infection due to inflammatory damage, there will be leak from the vessels, inflamed vessels, and that will leak the protein rich fluid. And wherever the protein goes, it takes the fluid with it. So protein needs fluid. If it is inside the vessel, the fluid will be inside the vessel. If protein leaks outside the vessel, it will take the fluid. So that happens in infections like tuberculosis and malignancy. And impaired lymphatic drainage can happen because of the compression or trauma. That happens in neoplasia. That is, mediastinal lymph nodes are enlarged in the malignancy. So in that cases, the lymphatic drainage is blocked. And the one which I have told previously about the Meek syndrome, the fluid movement from the peritoneal cavity to the ascites, and then from the diaphragmatic defect, it is going up to the right side of the pleural space. So I hope the pathophysiology is clear. So coming to the symptom part. In symptom part, the common symptoms which we see in pleural effusion are pleuritic type of chest pain. So what do you mean by pleuritic type of chest pain? Because in chest pain, whenever a patient tells chest pain in your OPD, you should know how to differentiate chest pain, which is of cardiac in nature, which is of pulmonary in nature, or which is of non-specific. So pleuritic type of chest pain is very typical for pleura. It is lateralized in location, means it will be in the infraaxillary area, because both the pleural layers are closely approximated there, and it is non-radiating. It will not radiate like our cardiac pain, and it is of pricking type. Like how you will ask? You will ask it like it will some needle or the knife is pricking from inside, and this pain aggravates on deep inspiration, coughing. Why? Because in deep inspiration and or coughing, the pleural layers are adhere to each other, or they are rubbing against each other. So that inflamed layer will have such symptoms. So this is a typical pleuritic chest pain. They can have dyspnea or shortness of breath, especially when the effusion is very massive, or there can be a parenchymal involvement like infiltration, consolidation, or any mass. Normally, the pleural-based diseases, they have dry cough. But if they are associated with expectoration, you should think of parenchymal etiology also. Understood? Fever can be there on and off. And in tuberculosis cases, it is low grade. But in empyema, it is a toxic, because there is a pus inside the body. There will be high grade fever. Hemoptysis can also be present in cases of malignancy or pulmonary embolism. Change or loss of voice, again, in case of malignancy, if it is involving the recurrent laryngeal nerve, especially on the left side. Loss of weight and appetite are the systemic symptoms, along with the low backache and fatigue. These are all systemic symptoms which can be present with the underlying diseases. And also we have connective tissue disease symptoms. In that, for rheumatoid arthritis, we have early morning stiffness of joints. And for systemic lupus erythematosus, there will be malar rash, and there can be dysphagia, okay, and some skin lesions. So all these are connective tissue disease symptoms. Coming to the signs. In signs, the first is tachypnea. Obviously, if the patient is having fluid inside the pleural,
Anna, time
so So there will come, lung will be there, and because of that, there will be increased respiratory rate. Tachycardia, respiratory distress, these two can be seen in massive effusion because of the mediastinal shift. Pitting edema or ascites, or what we call generalized edema, that is anasarca, can be present in transudative causes because of heart failure, liver failure, or renal failure, or hypoalbuminemia. Hypotension, again, in case of transudative effusion. Lymph node enlargement, yes, in cases of malignancies like lymphoma. And in general physical examination, we see the height, weight, and the body mass index to look whether the patient is properly nourished or not. Then we can go for pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. On inspection, we can see the contralateral shift of the trachea. So trachea will be shifted to the opposite side. For example, if the effusion is on the right side, if it is a massive effusion, which is collecting from above to the below, then there will be shift of the trachea. It can be seen with the trial sign. That is the elevation or the prominence of the sternocleidomastoid muscle on the opposite side. And because of the fluid, the lung expansion is not there. So the chest movements will be reduced on the affected area. And the apical impulse, which is normally felt in the left fifth intercostal space, there, because of the left effusion, we cannot feel it. Okay. These are all inspection. Palpation, the chest measurements are reduced on the same side because the movement is reduced. And the vocal fremitus, we have to palpate with our ulnar border and in the intercostal space and ask the patient to tell 1 or A. And we have to feel the vibration. If the vibrations are reduced, that means there is something between the two layers of the pleura. And as I told you, there will be widening of rib spaces. Because of the fluid collection, there will be widening of the rib spaces. Percussion, the classical percussion note is stony dull note. Why it is called stony dull note is when you are percussing over a pleural effusion, it looks like, it feels like you are percussing over the stone. Okay, you can feel slight pain in the lower aspect of the finger when you are percussing over the intercostal spaces. Cardiac and liver dullness can be present or absent depending on the side of the effusion. Shifting dullness present, it means that the fluid is free. It is not there in case of loculated effusion, which is confined to a particular area, or in case of massive effusion, because there is no place of the for the fluid to shift. So shifting dullness won't be there. In auscultation, yes, because there is no movement of the lung, the breath sounds are completely absent, and vocal resonance is nothing but same vocal fremitus, but now we are going to hear the same sound with the help of stethoscope. So that is also decreased over the affected areas. I hope the examination part is clear. So diagnostic workup. So what all diagnostic workup is required for this? How to go ahead? Can anybody guess or tell? Yes, pleural effusion assessment, good. Tapping, yes, tapping is must, it is needed, correct. But directly, will you go for tapping or you want to go step by step? Tapping is needed, definitely it is needed. Tapping and lights criteria, very good. Okay. So first we'll go with the blood investigations where we ask for a CBC, that is complete blood cell count. And in that we are going
Mediversal वालों का live webinar
or leukocytosis to look for any infection or empyema. And also we can see the platelet count. ANA profile and RF factor, especially for connective tissue disease, and serum amylase. Why do we ask for serum amylase? Can anybody tell? Serum amylase? Yes, pancreas. So pancreatitis can be diagnosed with the help of serum amylase. And LFT and RFT, that is liver function test and renal function test, mainly to look for cirrhosis or renal system disorders, and LDH to look for inflammation. Serology, because we are going to perform a procedure, so serology is required, and also to look for any other associated diseases associated with the retroviral disease. And NT-proBNP mainly for cardiac. Coming to the radiology, we are going to ask the chest X-ray PA, that is posterior anterior, if the patient is able
causes recurrent infections of the lung
lateral
and easier reason over time.
Have you heard of?
There are indolent infections that
or have you seen any lateral decubitus view of X-ray? Yes, why to relate pancreatitis with pleural effusion? Correct. Because pancreatitis itself is a cause. Okay. I have told in the etiology of the exudative effusion, pancreatitis can cause left-sided effusion. Okay. Can anybody tell what is lateral decubitus X-ray? Anybody heard of this type of view? Because it is used before. Now we got all the luxury of ultrasound, the what you call CCT, HRCT. We directly go for a very higher investigation. But when we didn't have all this investigation, what we used to do, we only had X-ray before. So lateral decubitus X-ray is an X-ray where the patient is asked to lie down in a lateral position and the X-ray is taken. Correct. So this was asked to determine whether the effusion is free flowing or not. Okay. So when the patient lies down on the same side in the lateral position, the fluid from the base, because the fluid will get collected in the gravitational position, no, the position which is having gravity. So the fluid from the base, it will come on the side. So we can see a straight line of the homogeneous opacity because of the shifting of the fluid. So this was used before, but not now because of the introduction of this ultrasound, HRCT, CCT, we can easily see. So ultrasound thorax, very important because it is the most sensitive investigation. Even 10 to 15 or whatever this 20 to 25 ml of the fluid can be detected on the ultrasound thorax. And also we have to ask ultrasound abdomen and pelvis to look for any abdomen and pelvic cause. Then we can go depending on the symptom and the signs, whether we require a HRCT or a CCT. If we feel there is a chance of malignancy, if there is a chance of pleural nodule involvement, mediastinal involvement, better to go for a contrast enhanced CT. If there is only parenchymal involvement, that is you are suspecting a TB, if there is a parenchymal involvement on the X-ray, better to go for HRCT. So pleural fluid aspiration, we call it as thoracentesis. There are two types, which everybody has answered, diagnostic and therapeutic. Diagnostic means the word only indicates we are going to diagnose, to identify the cause. Here we are going to aspirate only around 50 to 100 ml, which is sent for analysis. In therapeutic, we already know the cause. Okay, then it is done in cases of massive effusion where patient is having symptoms. So symptoms due to massive effusion, in that case, we are going to drain a large volume of fluid. Large volume also not beyond 1.5 liter. Why? I will answer the question. But this fluid is not sent for analysis because it is already diagnosed case. Here we are giving relief to the patient. That's why it is called therapeutic. So two types are there, diagnostic and therapeutic. These are the tests to be sent, pleural fluid analysis. Cell type means we are going to see whether it is neutrophil predominant, lymphocytic predominant. Cell count, whether the counts are increased, which counts are increased. Cytology, mainly for malignant cells, any atypical cells are present. Then cell block is again a histopath investigation, and hematocrit, very important for hemothorax. In microbiological, we are going to send a gram stain and culture to look for any empyema. If it is pus, yes, definitely it shows. Or if it is pneumonic effusion, it again shows a culture. AFB smear and CBNAT is for tuberculosis. For fungal etiology, we can send KOH mountain fungal culture. For biochemistry, we can see the pH, protein, glucose, ADA, LDH, and pleural fluid amylase. So that was a serum amylase, and this is a pleural fluid amylase. I will tell you the importance of each particular test. Okay, don't worry. I will tell you everything in detail. Then we can ask 2D echo because to rule out the cardiac cause. Bronchoscopy is done. Of course, bronchoscopy is required. I'll tell you when and where it is required. Thoracoscopy. Thoracoscopy is nothing but inspecting the pleural space. That is called thoracoscopy. So what do we see in the chest X-ray? In chest X-ray, the first earliest sign is blunting of costophrenic angle. And there will be a homogeneous opacity. And as somebody told, meniscus sign, that is Ellis S curve, which we have seen in our patient. There will be tracheomediastinal shift away, that is contralateral in case of massive effusion. Blunting of cardiophrenic angle. Loss of diaphragmatic, that contour, or what we call it as diaphragmatic curve. obscuration of the heart border, especially in the left-sided effusion, or there can be cardiomegaly in case of congestive cardiac failure related effusion. Lateral decubitus view, yes, which I have explained, confirms the free fluid, widening of the rib spaces, okay? And associated parenchymal abnormalities, like we have seen in our patients, bilateral lung infiltrates are there. Sometimes there can be a patchy consolidation in paraneumonic effusion, or there can be a cavity. So let us see the X-ray. This is our patient X-ray, what all findings he has. Can you see the red line? This is the costophrenic angle. On the right side, it is paired, left side, it is blunt. The cardiac border and the cardiophrenic angle, okay? The cardiac border and the cardiophrenic angle is also blunted. Can you see the diaphragm? Right side, it is clearly seen, left side, not seen. So there is a loss of diaphragmatic contour. This is a meniscus or Ellis S curve, okay? And this is the homogeneous opacity. I hope almost all the, like most of the signs our patient is having. The tracheomediastinal shift is not there because it is not enough fluid to push the heart and the trachea towards the opposite side, okay? These are few other X-rays, okay? This is a bilateral effusion where we can see the bilateral, the costophrenic and cardiophrenic angle are blunted with the homogeneous opacity in the lower zone. Diaphragmatic contour is also not seen. Cardiomegaly is also seen. This is again another X-ray, okay? Same, bilateral, blunting, homogeneous opacity, okay? Cardiomegaly. This is unilateral effusion, okay? And again, this side, the costophrenic angle is paired. This side it is blunted. A curve is there, Ellis curve. And the cardiophrenic angle, the left heart border is not made out. The left diaphragmatic border or the contour is also gone. So this is more of a kind of encysted or loculated effusion, okay? Loculated it is. Homogeneous opacity, the border you can make out. Yes, this is the massive effusion, okay? This is the massive effusion where we can see the, I'll come to that larger volume. Yes, I will come to that, okay, one by one. So this is a massive effusion. You can see the full left lung, okay? There is a full fluid, homogeneous opacity. You can't even see the costophrenic, cardiophrenic, the left heart border is completely gone. And you see the rib spaces here, but here you can see there is widening of the rib spaces. And yes, definitely what you have pointed is very good. You can see the trachea. Okay, I'm just drawing the border of the trachea. Yes, so it is definitely deviated. And you can see the cardiac border. Where is cardiac border? You can see the cardiac border. Yes, so there is a tracheomediastinal shift. Can you see? There is tracheomediastinal shift, right? So there is a tracheomediastinal shift towards the opposite side because it is a, it is a volume. Okay, the volume is increased here. Okay, so that's why there is a push of the organs towards the opposite side. Understood? Coming to the ultrasound thorax, I have already told it is most sensitive investigation. In this, the fluid appears anechoic or hypoechoic. Correct. And second thing is jellyfish sign. What is jellyfish sign? The fluid is compressing the lung. The collapsed lung, okay, it moves. The collapsed lung, I'll show you the image. The collapsed lung will move. Okay. So that is what it looks like, a wave-like fashion, which resembles like a jellyfish swimming. Okay. That can be seen in a real-time ultrasound. One more sign called plankton sign, which is suggestive of exudate or empyema, where we can see debris. And septations. Septations means there will be fibrin strands, which is forming the septation, which is seen in loculated or complicated effusion, which is infected. That means. So you can see this is the ultrasound image. Understood? This is the lung. Okay. This is the collapsed lung. Okay. And this is something what we call anechoic or hypo. Hypo means it is less brighter than the adjacent structure. Correct? So this is the pleural fluid. And this side is the liver. And this side is the lung. And this is a chest wall. Okay. And this is something called jellyfish. Okay, this lung. Okay, and this will be moving in a real-time ultrasound. Understood? So you have seen the jellyfish? Yes, it moves like a jellyfish. Understood? Coming to the CT thorax. In CT thorax, we can see both free and loculated pleural fluid, and they look like very low attenuation. They also look very dark when compared to the adjacent structure. And they are unilateral and exudative, except connective tissue disease, where it can be bilateral. And in transudative, it is always bilateral. Pleural thickening can be seen better in CT thorax, and it is seen in chronic and exudative effusion because of inflammation, or chronic because of fibrosis. There is something called split pleura sign, where both the visceral and parietal pleura are enhancing because they are having increased vascularity. And because of that, the contrast is reaching to that visceral and parietal pleura, and they will be appearing more brighter compared to the adjacent structure, which is suggestive of empyema. Pleural nodule or masses are seen in pleural malignancies like mesothelioma or metastasis from the abdominal secondaries. Compression or collapse of the adjacent lung because of the fluid can be easily seen in the CT. And underlying lung pathology like consolidation or mass or cavity is better seen on the CT. Mediastinal shift, of course, in large effusion, like we have seen on the X-ray, we can see the shift in the CT also. Cardiomegaly can be better seen on CT. So these are some images. I think you can see a CT image showing bilateral effusion. So always when you are seeing CT, I'll tell you one rule. Okay. When you are seeing a CT film, always it will be a cross. The right side will be on the opposite side. So if I'm seeing this CT film in front of me, this is my right side and this is my left side. Okay. Please remember this. Don't get confused. Always see the opposite side. If the patient is in supine position, the CT is done in supine position. Normally it is done in supine position, and you can see the right side. This is right side and left. So definitely we can make out right side effusion is more than left. This is a classical picture of transudative effusion due to cardiomegaly. So this is a cardiomegaly. This is a left ventricle which is dilated, and because of that there is a bilateral effusion. Okay, this is the mediastinal window, what we call, where we can see highlighting the mediastinal structure. Correct? That's why it is called mediastinal window. This is lung window, where we can see the lung parenchyma. Okay, this is the lung parenchyma. Correct? So in this, we cannot highlight the mediastinal structures. In this, we can highlight the mediastinal structures. I hope this is clear. Again, this is a CT which is showing the visceral pleural enhancement, red line, and the parietal pleural enhancement. And this is a collection, which is low attenuation compared to the adjacent area. So what is this? It is a split pleura sign, that is empyema, where there is enhancement of visceral and parietal pleura. Can anybody tell what is there in this X-ray? This is little new type of effusion, which I think most of you have not heard. Can anybody guess? It should be mutual, like it should be like an interactive class. Can anybody tell where is abnormality? Rib fracture, very good. Rib fracture is there. That's true. COPD, okay. Tubular narrow heart. Rib fracture is good finding. It's a associated finding, but I want the primary finding. Can you see the diaphragm, the right side of the diaphragm and the left diaphragm? Pneumothorax. You see the right side diaphragm is very far than the left. Correct. You can see the height of the right side of the diaphragm. So normally the diaphragmatic contour, what we can see here, normally the diaphragmatic contour, it goes like this and it peaks in the medial side. The diaphragmatic contour, it peaks on the medial side. But in this X-ray, it is peaking on the lateral side. Peaking in the sense it is more high. Okay. Normally what we see, the height is more. Yes, very good. That is a case of subpulmonic effusion where the height, that is the peak of the diaphragm, is shifted laterally. Understood? So you can see other X-rays. In this case, we can ask the right lateral X-ray. Right lateral X-ray. This is the right lateral X-ray of the patient. This is the right lateral X-ray of normal person. So normal person, you can see the right diaphragm is above than the left diaphragm. Can you make out this right diaphragm counter? And this is a left diaphragm counter. But here you can see the right diaphragm is here and left is here. So you can see there is a blunting. So this is subpulmonic effusion. I'll show you the CT. You can see the CT. The free fluid is accumulated just above the diaphragm. Okay, so in this, what happens? The fluid is not present in the lateral aspect. That is, normally our fluid is present in the visceral pleura and parietal pleura in the lateral aspect. But in this, it is in between the diaphragm and the diaphragmatic pleura. Okay, the lung base is like this on the diaphragm. It is sitting on this. So pleural fluid is present here. Okay, that's why it is called subpulmonic. Sub means below. Pulmonic is lung. Subpulmonic effusion. Understood? Again, one more X-ray. In this, we can make out the effusion is little larger. You can see the curve, homogeneous opacity, blunting, widening of the rib spaces, and there is a shift of the heart, not the trachea. Lower effusions can shift only the heart. Understood? This is a CT of the same patient. You can see the curve. Okay, there is a fluid. This is a bilateral effusion, homogeneous opacity, blunting of both cardiophrenic, costophrenic angle. Heart borders are not seen. They are dilated, and there are some increased markings. That means congestion is there. You can see the effusion, minimal effusion. Cardiac part is enlarged. So coming to the next part, that is called thoracentesis. Okay. Thoracentesis is, we are going to aspirate the pleural fluid from the pleural fluid cavity, either for diagnosis or for therapeutic. So for diagnostic, small amount of fluid is removed. Indication is any pleural effusion of unknown origin. Therapeutic is large amount of fluid is removed. The indication is to relieve the symptoms of dyspnea secondary to pleural effusion. The dyspnea should be due to pleural effusion. If the patient is having pleural effusion and severe anemia, anemia can be corrected and then see, yeah, the dyspnea persists, then it is due to effusion. Okay. How to position the patient? So positioning of the patient is very important in aspiration, that is pleural fluid tapping. The patient should be positioned with his back vertical so that the lowest part of his hemithorax is posterior. So the patient should be positioned like this, okay, with the pillow under his arm, and his back should be vertical so that the lowest part of his hemithorax is in the posterior aspect. So this is the position of the patient. How to select which site to aspirate? That is very important. Selection of the site is very important. By clinically, one intercostal space below the point where the tractal fragmentus is lost. Okay, if the tractal fragmentus is lost in 4th intercostal space, go one intercostal space below, 5th intercostal space. And you have to percuss. And when the percussion becomes from resonant to stony dull note, yes, one space below, you can go for site. It should be posterior approach and a few inches lateral to the spine. That is, ribs are easily palpable. And the needle entry should be above the ribs upper border to avoid intercostal artery, vein and nerve. Why? Because we have this intercostal space, and intercostal space, the upper rib, the lower border of the upper rib has a groove through which the artery, vein and nerve, the intercostal artery, the intercostal nerve and the intercostal vein will pass. So in order to avoid injury to these, we have to avoid inserting the needle at the lower border of upper rib. Okay, it should be upper border of the rib. Okay, this is the rib, these are the two ribs. Okay, and this is intercostal space. This is the lower border, this is the upper border. So lower border has artery, nerve and vein. The upper border is safe, so you can go just above the upper border. And ultrasound guided is done nowadays in order to avoid injury to the lung as well as to the adjacent organs. Okay, so this is how it is done. And what are the materials required? We can use a local anesthetic, lignocaine, either 1 or 2%. Then alcohol swabs to clean the area, antiseptic solution, sterile gloves, sterile drape with the central hole, which can be used to cover the adjacent area, and the hole is kept. Needle, 20 to 22 gauge needle. These are the 20 or 22 gauge needle can be used. Syringes, 5 ml to make local anesthesia infiltration, and 20 and 50 ml to make aspiration. 3-way stopcock. A 3-way stopcock is very important for therapeutic pleural aspiration. So in this, we can use a valve method. The syringe is attached here and needle is attached here, and this needle will be going into the pleural space. And if you keep the valve in this direction, you are going to aspirate fluid from here to there. Then we have to turn it. Okay, so the fluid will come from here to here. So here we are going to connect a IV set, and that tube will be going to the collection bottle. So aspirate, rotate the valve, and then push it. Then again, you have to rotate it back and aspirate. So every time you have to aspirate, rotate the valve, push. The fluid is coming out. So no need to remove needle every time. Okay. Again, turn the valve, aspirate, block the valve, set. Understood? So this is how it helps. 3-way stopcock. Then these are all for dressing: gauze pad, adhesive tape. So how is the technique? So explain the procedure. Any procedure you are doing, you have to first explain the patient, the procedure and the complications, and you have to take a signed consent from the patient. Second is marking the site. With the help of ultrasound, mark the site, or with the help of clinically, one intercostal space below the stony dull node or tactile vocal fremitus is lost. Second, clean the site, because if you don't clean and if you insert the needle, you are going to insert infection into the pleural space. Local anesthesia of infiltration of the skin, periosteum and parietal pleura, because it is pain sensitive. Then go for fluid aspiration. So this is how we have to do. This is a needle going into skin and subcutaneous tissue, local infiltration anesthesia. Then going into the periosteum level. Okay, these are the spaces, and you can carefully observe here. This is a rib, upper rib, lower rib. This is the intercostal space. The 3 dots which you can see here are artery, nerve and vein. And where is the needle? Needle is in the upper part. So you should not be touching the rib. Neither you should be going in the lung, nor you should be going into the diaphragm. That is, below the diaphragm, you have right side liver, left side spleen. So there can be chance of injury. So please be careful, and the needle should be exactly above, and it is entering into the fluid. And maximum fluid aspirated is 1 to 1.5 liter per setting. Somebody has already told re-expansion pulmonary edema. I'll come to that. If it is aspirated more than 1 to 1.5 liter in one setting, in one go, then there is a chance of re-expansion pulmonary edema. That is one of the complications. So coming to detailed pleural fluid analysis, where we are going to send again the same table. Okay. And what is Light's criteria? Okay. Can anybody tell what is Light's criteria? Why it is used? Light's criteria. Somebody has mentioned already Lights. Yes, very good. So Light's criteria is used to differentiate exudate versus transudate. Very good. So what does this Light's criteria tell? The pleural fluid protein to serum protein, the ratio should be less than 0.5 in transudate and more than 0.5 in exudate. Pleural fluid LDH to the serum LDH less than 0.6 in transudate, more than 0.6 in exudate. Pleural fluid LDH should be more than 2/3 of the upper limit in exudative. It is less than 2/3 of the upper limit in transudative. So you are like, sir has told how to remember. So easy thing I will tell you to remember. In transudate, it is not because of the protein leak. Okay, it is the fluid which is going out. So when you see the pleural fluid protein is more compared to the serum protein, the ratio will automatically increase. Okay, if the serum protein is more and the pleural fluid protein is less, the ratio will automatically decrease. So please keep that in mind. In exudative, the protein is more in the pleural fluid, so the ratio will be more. Now, how to remember 0.5 and 0.6? Because if somebody tells protein is 0.6 or protein is 0.5, we don't remember. So easy thing to remember is LDH is 3. LDH. So 3 into 2 is 6. Understood? So always remember 3 LDH, that should be 0.6, either more than 0.6 or less than 0.6. So in this way, you can remember the simple logic of Light's criteria. Okay, this is very tricky. Pleural effusion or the pleural fluid, what we aspirated is little blood or a blood tinge. So how to differentiate? What we have to do for differentiating whether it is a hemothorax or not, I have already told before. Can anybody tell what investigation to send? I already discussed in the previous slides. You guys have to concentrate, otherwise there are MCQs at the last. You guys have to answer. Yes, very good. Hematocrit. So we have to send hematocrit. Okay. And what should be the hematocrit level to call it as hemothorax? Very good. I hope yes, very good. More than 50%. Very good. You guys are concentrating. Very good. So if the hematocrit is more than 50%, it is hemothorax. Sorry, it is little misaligned. If the hematocrit is more than 50%, it is hemothorax. Understood? If it is more than 1%, it is malignancy. And if it is less than 1%, it is not significant. Understood? And this 50% should be more than that of the peripheral blood. Understood? But if hematocrit is not available, what to do? Pleural fluid RBC you have to send. Pleural fluid RBC should be more than 50% of the peripheral RBC count, which indicates hemothorax. So this is a very important slide. I'll take time 10 minutes to explain this slide. Please be attentive for this slide. This is an important slide to differentiate which type of effusion is there depending on the pleural fluid analysis. I don't want you to remember everything, just a highlighting point. If it is pale yellow or a straw color, more of tubercular. If it is purulent or turbid, more of bacterial. If it is hemorrhagic, more of malignant. Hemorrhagic means not more than 50%, okay? Less than 50%. That is up to more than 1%. And if it is a frank pus, it is empyema. So depending on just by seeing you can tell what could be the etiology. Then in case of cell type, bacterial and empyema are acute onset. So we have acute inflammatory cells, neutrophils. Whereas tubercular and malignancy are chronic. So we have a lymphocyte predominant. Okay. And in case of bacteria and malignancy and empyema, what happens? Even the infections, they are consuming the bacteria, they are consuming the glucose. So glucose will be low. In empyema, the bacterial growth is more, so it is very low. And malignant cells, they are also glucose hungry. They also make the glucose on the lower side. So remember like that. But in tubercular, it can be normal or mildly low, not very low. But when you see the LDH is a marker of inflammation. So among these four, which particular entity has highest inflammation? Empyema. So that's why the LDH is very high. But when you come to ADA, normally we see ADA, pleural fluid ADA is high, it is tubercular. Yes, it can be tubercular if you are correlating the clinical sign and symptom. But don't assume only ADA to name it as tubercular effusion, because ADA can be elevated in tubercular, can be elevated in malignancy, it can be very much high elevated in empyema. Always correlate pleural fluid analysis with the clinical symptoms, with the radiological feature, and then term it as a tubercular effusion. Don't just term it as tubercular effusion only on pleural fluid ADA elevated. Please remember this point. Okay. Yes, I'll explain about LDH and ADA. LDH is a inflammatory marker. Okay. The more the LDH, the inflammation will be higher. That's why the LDH is highest in the empyema. And ADA, I will explain in the next slide. Okay. Now, let us think the pleural fluid is turbid or milky. So what is your diagnosis if the pleural fluid is milky? If there is a milk or milky pleural fluid, what can be your diagnosis? I have discussed again. Yes, very good. Chylothorax. Okay. So if the pleural fluid is turbid or milky, it is chylothorax, or if it is turbid, it can be empyema, or it can be a pseudo-chylothorax. Okay, it can be pseudo-chylothorax. So how to differentiate this? So we have to subject that pleural fluid which is turbid or milky to the centrifugation. After that, if the turbidity clears, then it is due to cell or debris, and that is seen in empyema. If the turbidity persists, then it is chylothorax or pseudo-chylothorax. So this is a simple test. Take the pleural fluid, subject it for centrifugation. If it clears, it is due to cell or debris, empyema. If it persists, it is chylo or pseudo-chylothorax. If these tests are not available, bedside you want to differentiate chylothorax from pseudo-chylothorax. What you have to do? You have to use ethyl ether. It's an organic solution which can be used, quick bedside test to differentiate whether it is chylothorax or pseudo-chylothorax. How? I will explain. The principle of this is the chylothorax which contains chyle, as I already told you, is having triglycerides. Okay. And these are in the form of chylomicrons. And these chylomicrons, they are soluble in ether. Okay. This is a principle. So you take a small sample of that milky pleural fluid, put few drops of ethyl ether and mix. Okay. If it contains triglycerides in the form of chylomicron, it get dissolved. It get soluble. It get dissolved in the particular solvent. So the milky appearance clears because the ether dissolves the fat. Then it is chylothorax. If the milky appearance persists, even if you add the drop, that means it is pseudo-chylothorax because it has cholesterol crystals which are not emulsified. I hope you got this test. This is a simple bedside test which can be done. Understood? Yes, what you are asking, I got that same. The chylothorax and pseudo-chylothorax. The definition of chylothorax is accumulation of chyle, and in pseudo-chylothorax, it is a chronic pleural effusion with cholesterol crystal accumulation. The causes are already discussed: thoracic duct injury and malignancy. In case of this, there is long-standing effusion due to tuberculosis or rheumatoid pleuritis. Appearance is same, but the triglyceride level is higher in chylothorax. It is lower in pseudo-chylothorax. And the cholesterol level is higher in pseudo-chylothorax and lower in chylothorax. Cholesterol crystals present in the pseudo-chylothorax, not in the chylothorax. So what we have to remember is the triglyceride level is higher in chylothorax. Cholesterol crystals and cholesterol level are higher in the pseudo-chylothorax. This is a acute or subacute condition. This is a chronic condition. So any patient coming with a chronic condition and a pleural fluid showing milky, don't think of chylothorax, think of pseudo-chylothorax. Understood? As somebody asked, ADA, adenosine deaminase, it is a very important pleural fluid marker. The cutoff we take 40 to 45 in the pleural fluid because the cutoff varies in the different fluid. The pleural fluid, the cutoff is 40 to 45. There are two types, ADA1, ADA2. ADA2 is more specific for TB effusion, but we calculate entire ADA. We don't calculate separately ADA1 and ADA2 because it is costly. We take ADA, which is combination of ADA1 and ADA2. This adenosine deaminase is mainly produced by T lymphocytes, monocytes, and macrophages. And they have very high negative predictive value. It can be elevated in TB, empyema, malignancy. But if it is normal, it straight away rules out the tuberculosis. So that is why it is called high negative predictive value. If the ADA is normal, less likely you think of tubercular pleural effusion. Because the elevated causes can be different. That's why I told you, always correlate clinically, radiologically, and the lab investigations. Then you come for a diagnosis. Hyaluronic acid. Can anybody tell hyaluronic acid in pleural fluid is marker of which disease? Can anybody guess? NPV means negative predictive value. Negative predictive value means the test can effectively rule out the disease. If the value is low, it effectively rules out the disease. If the ADA is low, less likely the chance of TB pleural effusion is high. Hyaluronic acid is a pleural fluid marker in malignant mesothelioma, which is involving the pleura. Okay, so hyaluronic acid is a pleural fluid marker for malignant mesothelioma. For Meeks, we are going to use CA 125, but it is not specific. Okay. Okay, this is also a very important slide. Now, if a patient is having left-sided pleural effusion, it is either due to a esophageal cause or a pancreatic cause. So esophageal cause and pancreatic cause, they cause left-sided pleural effusion, and they are all massive. So how to differentiate? The one thing which we send in pleural fluid for esophageal and pancreas, what do we send for esophageal and pancreatic cause? What? Lipase, okay. More sensitive, amylase, very good. Amylase is sent in pleural fluid for esophageal or pancreatic cause. But in our body, there are two isoforms of amylase. We have a salivary amylase and a pancreatic amylase. Salivary amylase is increased in esophageal cause, and pancreatic amylase is increased in pancreatic cause. So this is to differentiate esophageal and pancreatic cause. Understood? So what are the complications of thoracentesis? The most common complication is pneumothorax when we puncture the lung, commonly seen in COPD patients because they are having emphysematous lung, and the X-ray should be done post-procedure. The X-ray should be done post-procedure. Yes, chances of esophageal and pancreatic effusions are more common on the left side. Okay. Yes, hemopneumothorax can also happen. Yes, patient can start coughing either because of re-expansion pulmonary edema, or it can be due to injury to the lung. Chest pain can happen. Yes, of course. Vasovagal reflex. Some patients may have increased sensitivity to pain. Because of that, they can go into vasovagal reflex, causing bradycardia, hypotension. Yes, if you don't clean, if you don't do it into a sterile condition, then infection of the pleural space can happen. Bleeding and hemothorax, that can also happen. If you go more down, spleen or hepatic laceration can happen. Sometimes if it is tumor, we can seed them through the needle track. And yes, adverse reaction to local anesthetic agent. That's why we should give a test dose of local anesthesia before giving them. And re-expansion pulmonary edema. Re-expansion pulmonary edema happen if the lungs are collapsed for more than 72 hours. And suddenly you are going to drain more than 1.5 liter. Then there will be sudden re-expansion. And because of that, there will be mechanical injury to the vessels, leading to pulmonary edema. So that is why re-expansion pulmonary edema is a life-threatening complication of pleural fluid aspiration. But in this pleural fluid aspiration, we have a control how much we can aspirate. It more likely to be happen in pneumothorax, where we insert ICD if the lung is collapsed for more than 3 days and suddenly the lung expands. We cannot control the gush of air coming out. So more likely it happens in ICD insertion in pneumothorax than the pleural fluid aspiration. Yes, post-tussive syncope can also happen. That is what we call cough, and then patient will go into syncope. Coming to the treatment of pleural effusion. So how do you treat pleural effusion? Pleural effusion can be treated depending on the etiology. Transudative effusions have a systemic cause. So we have to treat the cause, like congestive heart failure, cirrhosis, nephrotic syndrome, or hypoalbuminemia. Whatever the cause is there, treat the cause. Don't go to tap the fluid. Don't go to do the therapeutic aspiration. Just treat the cause. It will clear. Therapeutic thoracentesis is required only if it is very large and symptomatic. Intercostal drain is generally avoided in purely transudative effusion because the cause is not the fluid. The fluid is getting accumulated due to some other cause. If you keep draining the fluid, that will cause hemodynamic instability in the patient. Exudative effusion, the causes of exudative effusion, parapneumonic or empyema. In this, obviously, we'll start with the broad spectrum antibiotics. And if it is empyema, definitely we have to go for complete drainage with the help of intercostal drain. And if there are septations, fibrinolytics can be injected. And VATS is video-assisted thoracoscopic surgery, where with the help of thoracoscope, we are going to break those adhesions and drain the pus. In tuberculosis, anti-tubercular therapy has to be started, and it has to be given till 6 months, 2 months of intensive and 4 months of continuous phase. Therapeutic aspiration is required only if it is large or asymptomatic. Otherwise, diagnostic aspiration is enough to diagnose. ICD is rarely needed unless there is a empyema due to TB. If there is pus or blood, definitely you have to drain. There is no other option. In malignant effusions, Repeated aspiration can provide symptomatic relief. We have an indwelling pleural catheter, which can be inserted instead of intercostal drain for recurrent symptomatic cases, and something called pleurodesis for recurrent effusion, and the lung should be expanded and treat the primary cancer. Mesothelioma is a pleural malignancy. Again, we have surgery, chemotherapy, radiotherapy, aspiration or indwelling catheter again for symptom control, and pleurodesis in order to avoid recollection of the pleural fluid. Yes, pleurodesis, I'll come to that. Hemothorax, I already told you, if there is a blood, definitely you have to drain as soon as possible. And if you see, if there is more than 1500 ml of blood is coming in the beginning, or it is continuously coming up to 100 ml per hour, then of course you have to definitely go for surgery. You have to correct the trauma source and you have to correct the coagulopathy if it is there. Pancreatitis or esophageal rupture, commonly on the left side. Treat the pancreatitis. Thoracentesis only if it is symptomatic. Otherwise, no need to do. If you treat the pancreatitis, it will resolve on its own. Esophageal rupture, again, surgical repair with a broad spectrum antibiotic. Connective tissue disease, these are the only exudative cause which presents with bilateral effusion. You have to treat the primary disease. Immunosuppressants and steroids can be used. And again, if it is large or symptomatic, therapeutic aspiration can be done. Meeks syndrome, what we can say is surgical removal of the benign tumor, clears of the fluid, ascites, as well as the effusion. Supportive can be done aspiration if it is symptomatic. So in all these cases, if you treat the cause, it will come down. Symptomatic cases, definitely you have to go for therapeutic aspiration. But in case of malignancy, ICD or indwelling pleural catheter can be used. In case of hemothorax, definitely you have to drain with the ICD tube. Chylothorax, in this, you have to treat the cause. The main risk is don't go for repeated drainage. Please keep this in mind. If there is a chylothorax, don't keep on draining. Okay, because the chyle is rich in protein, fat, electrolytes, and lymphocytes. The more you drain, the more you are removing that from the patient's body, and that will cause him malnutrition and immunosuppressed. Okay, so that is the main risk which happens in chylothorax. Don't drain it. I'll tell you what to do. There are drugs like somatostatin, analogs, octreotide, which reduces the chyle flow by lowering the intestinal fat and promoting the leak closure. Or we can make a pleuroperitoneal shunt so that the chyle remains in the body. Or we can go for blockage of this thoracic duct or ligation of the thoracic duct, so that in order to avoid spillage of this chyle into the pleural space. And last but least is pleurodesis. Okay, so we will come to the pleurodesis part. So before going to pleurodesis, ICD insertion, that is intercostal drainage insertion. So in this, the purpose of this drain is you have to remove the fluid, you have to remove the pus, blood or air from the pleural space. And ideally it is inserted in the triangle of safety. So what is triangle of safety? This is a triangle of safety. Okay. So anteriorly, this is anterior, this is posterior. It is bounded by pectoralis major muscle border. Posteriorly bounded by latissimus dorsi. Below fifth intercostal space. How to remember? Safety, yes, and 5. Fifth intercostal space. And the superiorly by base of axilla. So this is called as triangle of safety, where we can safely introduce the intercostal drain tube. So this is an image of intercostal drain tube with a trocar. Okay. So trocar will be inserted inside. Okay. Just one nick. Okay. And then we are going to insert the tip. And after that, we have to remove the trocar and just forward the plastic catheter. And this is a drain bag. This end of the bag is connected to this, and here the fluid or air will get collected. What is indwelling pleural catheter? It is used for long-term drainage for recurrent malignant or chronic effusion, and it provides symptom relief without repeated thoracocentesis, because this catheter is inserted and it is locked. The patient can go home, and whenever the patient has more symptom due to collection of fluid, patient can come. That lock will be opened and connect to the drain chamber, that will be drained, and again it can be locked. So in this way, you can use it for patients who are having recurrent effusion and poor surgical candidates in whom the surgery cannot be performed. The advantages of this over the ICD is the hospital stay is less, invasiveness is less, the pain and the risk of infection is also very low. And with the help of indwelling pleural catheter, the spontaneous pleurodesis can happen. So this is a animated image of indwelling pleural catheter, which will be inserted and kept. Okay. No, if you maintain the pleural catheter, if you maintain it, the hygienity and all, less likely the chance of infection is there. You have to, even ICD care also has to be explained to the patient, okay, how to keep it clean. So less likely there will be chance of infection if you maintain the hygiene. Pleurodesis. Can anybody tell what is the meaning of pleurodesis? Pleurodesis, what do you mean by pleurodesis? Yes. So the literal meaning of that is both the layers. Like, have you heard of arthrodesis? Arthrodesis is we are going to, yes, fix the joint. So in this, we are going to fix the two layers of the pleura so that the fluid accumulation or air, okay, that will not happen in the future. If it is a case of recurrent massive effusion, that is called pleurodesis. So here we are going to obliterate the pleural space to prevent recurrent effusion or pneumothorax. Again, yes, there are two types. Either we can use a chemical agent, that is called chemical via ICD, or thoracoscopy with the help of that is mechanical. It induces inflammation and both the pleural layers are adhered to each other with the help of fibrosis. Understood? This is done in case of recurrent malignant effusion or recurrent pneumothorax. So you can see the layer here, parietal layer, visceral layer. The scar tissue will make the parietal and visceral layer close to each other. The chance of collection of fluid again will be less. Pleural biopsy. Okay, so this is one of the investigation which we use whenever the undiagnosed exudative effusion, okay, means if the effusion is exudative and we didn't get any cause, especially the TB or malignancy, then the gold standard investigation is pleural biopsy. You take the biopsy from the pleura. If there are nodules, if there are thickening, take from there. Otherwise, take from pleural biopsy. Two types are there. Video assisted thoracoscope. It is like a laparoscope only. Thoracoscope we are going to insert with the help of 3 ports. And then we are going to inspect and take biopsy from the pleura, or open directly. We take a long incision and then open, and then we can visualize directly and take the pleural biopsy. So it is minimal invasive. It is more invasive. Here there is small incision is there, and here it is large thoracotomy incision. The diagnostic yield is high in both, but in this it is very high because we can directly visualize. But since the incision is very high, the hospital stay is longer and pain is more and risk is more of infection and bleeding. Here it is safer. The recovery time, the operative pain and the infection and bleeding is safer. Understood? Yes. So pleural biopsy has become go-to investigation now because of availability of VATs. That's very good. And this is a gold standard when you don't get the diagnosis in the initial investigation part. So this is how VATs is performed with the help of a thoracoscope. And this is how the thoracotomy is performed in posterolateral approach. So incision is quite big, and here it is small 3 incisions are there. So that's why this is more riskier and more hospital stay compared to the VATs. So anybody remember our case where we left? Our case, we had a probable diagnosis of biopsy from the parietal pleura. So we had a case, remember, probable diagnosis was left-sided moderate pleural effusion and reevaluation, correct? Yes. So what to do next in this? We have done an X-ray, ECG, blood test. What to do? We have done ECG and a chest X-ray. Now you have admitted the patient. Your diagnosis is left-sided moderate pleural effusion under evaluation. So what to do? What is the next step? Can anybody tell what is the next step? Yes. So what we can go is one by one. Blood tests. CBC was showing anemia with the lymphocyte count elevated, lymphocytosis. Renal function test, liver function test were within normal limit. Serology, non-reactive. diagnostic pleural fluid aspiration done, which was ultrasound guided. Okay. And it was showing pale yellow, clear fluid, predominant with the lymphocyte, protein high, glucose normal, ADA 54, LDH is high, gram stain and culture, no growth. Patient had cough with expectoration, so we had sent for sputum for AFP and gene expert, detected AFP positive, and rifampicin resistance not detected. So what is our diagnosis? Microbiologically diagnosed pulmonary tuberculosis with EPTB. What is EPTB? Extra pulmonary tuberculosis, that is tubercular pleural effusion. So please remember, tubercular pleural effusion is an extra pulmonary TB. But our patient had sputum AFB and CB net positive, so we are going to term it as microbiologically diagnosed pulmonary tuberculosis with extra pulmonary tuberculosis. So don't tell it as a pulmonary TB, just pulmonary TB. Understood? Pulmonary TB with extra pulmonary tuberculosis. So he was started on anti-tubercular therapy as per his weight band under National Tuberculosis Elimination Program. So this was the first X-ray which we have seen during the admission. After 2 weeks of anti-tubercular therapy, can you see any difference in the X-ray? After 2 weeks of ATT. Yes, the opacity has reduced, and when you compare the left-sided infiltrates, they have also reduced, and patient has improved clinically. Patient has improved clinically. So a clear diagnosis is a right treatment and a smiling patient. That's our real success story. Understood? Okay, so before going to MCQs, there are certain interesting facts. There are certain interesting facts about the pleural effusion I will discuss. Okay. One thing to differentiate is the total lung collapse versus massive pleural effusion. Okay, why it is important, I'll tell you. Just see this X-ray. Is this a effusion? Can you see the X-ray? Is this an effusion? No. Very good. Why? Because the opacity is covering the entire lung, but still the shift is on the same side. Correct? So less likely this is an effusion. Other thing is, you can see the intercostal space, they are narrow. And what has happened to the diaphragm? It is elevated. And what has happened to the trachea? Yes. So trachea is also shifted to the left. You can see slight deviation is there. Understood? I'll show you the difference. Now see this X-ray. Compare these two X-rays. What has happened? Opacity is there. Yes, both sides. Here it looks like volume loss. Here it looks like volume is gained. Okay. Shift is on the opposite side. Shift is on the same side. Rib spaces widening, narrowed. What about the diaphragm? Pushed down. It is almost not seen. Heart border not seen. Here also not seen, but it is pulled up. Cardiac is also pulled up. Okay. So these are the two X-rays. Okay. If you see, you should be able to differentiate whether it is a massive effusion or it is a total lung collapse. So I have put it in contrasting way so that you can understand. Understood? Can pleural effusion have ipsilateral mediastinal shift? I was keep on telling that pleural effusion can have contralateral shift, but can pleural effusion have ipsilateral mediastinal shift? Can they have? Yes or no? Yes, they can have. Okay. Not necessary that whenever there is a fluid, it causes shift. Sometimes there is a fluid and shift will be towards the same side. Okay. Not necessary. So yes, they can have. In most of the pleural effusion, the mediastinal shift is opposite side, but in rare of the rare pathology, the shift can be on the same side. So let us see what are the two causes. So this is an X-ray. Can you see the X-ray? The trachea is shifted here. You can see this is trachea shifted here. Cardiac is also shifted here. Correct? And this is a CT of the same patient, where you can see this is an effusion part, okay, and this is a collapsed lung. Little bit down, again an effusion part, okay, and a collapsed lung, okay. This is a right main bronchus, okay, and this is a left main bronchus. You can see as it goes down, right main bronchus is getting narrowed. Here it is completely gone. Effusion is there, collapsed lung is there. And can you compare the rib spaces here and here? So that's why CT gives you detailed idea. You have to see everything in the CT, not just this part and then leave it. No, you see the rib spaces here and compare here. They are increased. Understood? So what are the two causes? The first is there can be a endobronchial lesion. Inside the bronchus, there is a lesion which is causing collapse of the lung, and there is effusion. So it will be shifted towards the same side. Or there is a malignant mesothelioma, where the pleural malignancy, which is encasing the lung, and it is pulling it towards it. Understood? So these are the two causes where there is ipsilateral mediastinal shift can happen. So endobronchial lesion is there with a complete collapse. What is the diagnostic modality? You have seen the CT, you have done, you can assess there is a shift and the effusion is on the same side. Now what diagnosis, what investigation you want to do to get a diagnosis? Diagnostic modality means the investigation done to get a diagnosis. Can anybody name diagnostic investigation? I have already discussed this diagnosis in my diagnostic workup side. Yes, very good. Bronchoscopy. Video bronchoscopy has to be done in endobronchial lesion when there is a complete collapse, because we get the tissue from the lesion and then we are going to send it for histopath. Malignant mesothelioma. Pleural fluid marker is hyaluronic acid. I already discussed. Hyaluronic acid is the pleural fluid marker. Okay, there is a question for you all. Can a transudate effusion becomes an exudate effusion? Can a transudative effusion becomes an exudative effusion? No. Anybody else? Yes. Yes, there is a probability that the transudative effusion can become an exudative effusion. There are two causes. One is when the underlying transudative effusion due to heart failure can get infected, or there is a presence of malignancy, then there is a chance of transudative getting into exudative. That is called true exudate. It is a true exudate because there is a cause. Understood? There is a superadded cause. That's why it is called superimposed pathology. Second cause is post-diuretic effect, which is normally seen in ICU. A patient of congestive heart failure is admitted. He is having bilateral effusion. They have given diuretics. So what happens is the fluid will be gone. But what about the protein and LDH which is present in the fluid? It is still remaining. So when you perform a tapping there, it makes the transudate looks like exudate as per the Light's criteria. But no, it is not a true exudate. It is a pseudo exudate. The underlying cause is the same. Just because we have given diuretics, the fluid is gone. The LDH and protein will take time to go. If you tap at that time, the Light's criteria will show it as an exudate, but it is a pseudo exudate. And this is a true exudate. So these are the two causes where a transudate effusion can become an exudate effusion. Understood? One more question. Can bilateral effusion will have two different causes? A patient has come with a bilateral effusion, and this side it is showing one cause, and this side it is showing some other cause. Can it happen? Yes, definitely yes, it can happen. It can happen, and the incidence is very, very rare. Don't think it in almost all the cases. It is very, very rare. Less than 1% chance is there in bilateral effusion to come out as a two different cause. Means right side, the most common finding was right side was transudative effusion from heart failure, and left side there was a consolidation causing parapneumonic effusion. Or the other was chylothorax on the right side and a malignant effusion on the left side. So lymphoma causing effusion, malignancy on the left side, and there is chyle on the other hand. So anybody tell what is the name of this condition? Can anybody tell? Yes, everything is possible in medicine. That's true. But we should know everything to diagnose it. That's the beauty of doctor. So can anybody tell what is this condition called? Meeks? No, Meeks is the condition where the ovarian tumor is coming. This is called Contarini condition. I think you guys have not heard of it. Contarini condition is a condition. He was the first who described this, where the two effusion is having two different cause. That is called as Contarini condition. Understood? So this is a handwritten note from me. I'll just tell you in brief. When you don't get any investigation positive for tuberculosis or malignancy, we have gone for contrast CT or CT pulmonary angiograph. CT pulmonary angiograph is showing embolism, treat it. If it is showing parenchymal abnormalities or endobronchial, go for bronchoscopy. If it is showing mesothelioma pleural, then go for pleural biopsy or thoracoscopy. If that is also not giving any result, okay, and you see clinically, patient is having symptoms, patient is worsening, go for thoracoscopy. So here, the pleural biopsy with the help of thoracoscopy comes into play. Understood? So that is the gold standard investigation in any exudative effusion which is not giving result for TB or malignancy. Understood? So there was one interesting case which I had seen long back. This case was a 55-year-old male. He had a history of buccal mucosal carcinoma and he has undergone radiotherapy. He presented to our OPD with the shortness of breath, and on X-ray it was showing right-sided massive pleural effusion. Pleural fluid aspiration was done, diagnostic as well as therapeutic to relieve his symptoms. It was hemorrhagic, exudative, lymphocyte predominant, ADA was borderline, cytology was negative for malignant cell. We performed a CCT which showed a nodular pleural thickening. There was no any parenchymal or lung involvement. Bronchoscopy again done, which is normal, no endobronchial lesion. Thoracoscopic pleural biopsy was done, which showed well-differentiated squamous cell carcinoma. So this case gives an idea about a rare distant metastasis from buccal mucosal squamous cell carcinoma to the pleura. So that happens in 0.5 to 2% of the cases. So this was a chest X-ray, massive effusion with a shift. You can see crowding. Okay. This is a CT of the same patient with a massive effusion. And this is a histopath, which is showing keratin pearls. It's a classical picture of squamous cell carcinoma. Okay. So this is the classical picture of squamous cell carcinoma. Understood? So coming back to the quiz. So this is the last part of the today's live webinar. So are you guys ready for the quiz? I'll give you 10 seconds. You have to answer. Okay. All are true about the anatomy of pleura, except there are two layers, visceral and parietal layer. Both the parietal pleura lines the inside of thoracic cavity. Both visceral and parietal pleura are lined with a single layer of flat mesothelial cell. Sensory nerve endings are present only in the visceral pleura. Very good. Everybody has answered correct. Very good. All are causes of bilateral pleural effusion except. Second. Okay. Second. All are causes of bilateral pleural effusion except. Very good. So congestive cardiac failure, bilateral, cirrhosis, bilateral. SLE is the exudative cause, which is bilateral. Tubercular is unilateral. Bilateral exudative pleural effusion is seen in third question answer. Bilateral exudative pleural effusion is seen in. Come on, I have told this multiple times. Bilateral exudative pleural effusion. Think. See, first it is bilateral. So among these, which is bilateral? Congestive cardiac failure is bilateral. Connective tissue disease is bilateral. This is unilateral. This is unilateral. And among these two, which is exudative? CTD is exudative. Okay, so like this, you break down the question and answer. Pleuritic chest pain is characterized by all except. Answer to question number 4. Lateralized in location, dull aching, increase on coughing, increase on deep inspiration. Good. Straightforward answer, dull aching. It should be like a pricking type, correct? Should be pricking type. Right-sided massive pleural effusion is characterized by all except shift of trachea to the left side, reduced chest movement on the right side, absence of apical impulse, stony dull note percussion over right side. Which is not present in right-sided massive effusion? Think. It's a clinical question. Yes, mixed responses, B, C. Think. Apical impulse is absent on right-sided effusion or left-sided effusion? Left-sided effusion. So we are going to discuss right-sided. Yes, trachea will be shifted on the opposite side. Chest movements will be reduced on the same side. Stony dull note will be percussed over the right side. Apical impulse will be shifted more laterally, not absent. All are true about Light's criteria, except it helps in differentiating between exudative, transudative, fluid protein, serum protein of more than 0.5 is transudative, fluid LDH upon serum LDH is more than 0.6 is exudative. Good. You got the trap. The protein and serum protein should be less than 0.5. Okay. If I change only one, this mark, it will become wrong answer. Understood? Good. You guys have very good eyes. All are true about thoracentesis except it should be attempted one space below. Percussion note becomes stony dull. Ultrasound is superior to chest X-ray. Needle entry should be attempted inferior to a rib. Patient should be positioned with his back vertical so that lowest part of his hemithorax is posterior. Good. Needle entry should be attempted superior to the rib. Okay, not inferior to the rib. Very good. Because to avoid damage to the intercostal artery and nerve and vein. Okay. Complications of thoracentesis are all except yes, hemothorax can happen, pyothorax can happen, pneumothorax can happen. Urinothorax is presence of urine in the pleural space. It's less likely. Pleural fluid marker for malignant mesothelioma. I guess you guys will not forget what has to be sent for malignant mesothelioma. It is hyaluronic acid. ADI is used for tuberculosis to rule out amylase. Lipase is for pancreatitis. All are advantages of indwelling pleural catheter over intercostal drain tube, except last question. Come on. I know I have taken a lot of time. This is last question. Hospital stay is less, correct. Risk of infection is less, correct. Spontaneous pleurodesis can happen, correct. Yes, it is less invasive compared to ICD, not more invasive. Very good. So every patient you treat is a chapter in the story of your medical journey. Make every one worth reading. So every patient you treat, consider them as a chapter, not just from the book. Patients are also your teacher. They also teach you. So I hope I have almost covered the entire pleural effusion.
Thank you so much, Dr. Sohail. I request everyone to write their questions in the chat box. We will be starting the Q&A session and Dr. Sohail will answer them one by one. And meanwhile, I'll also be sharing the certificate registration form in the chat box. Everyone please fill the form and get your certificate on your mail IDs. You can write down your questions in the chat box.
I hope I was very clear. I know it was a lengthy, but I wanted to cover each and every aspect. so that you guys should not think, oh, sir has not taught this in our webinar. So any effusion comes to your OPD or IPD, please go through in a systematic way. You can reach diagnosis and you can treat the patient. If anybody is having any question, they can ask. Urinary thorax can also possible. There is some possible communication is there between kidney and pleural space. That is not very common, rare. That can also happen. I hope I have simplified this pleural effusion for you guys as possible as I can. And I have shown you all these X-rays and CTs which are real. Okay.
So I guess you were very clear in today's session, Dr. Sohail. No one is having any question.
Yeah.
So, yeah, I guess so. So thank you so much, Dr. Sohail, for this insightful session. On behalf of everyone, I would like to extend our sincere gratitude to you, Dr. Sohail. Thank you, Dr. Sohail.
Thank you, Shabnam, and thank you, Mediversal, for arranging this live webinar. And I was able to share my knowledge with everybody. It's a great experience. Thank you.
Thank you so much. And thank you everyone for joining us for today's session. If you are having any further questions or would like more information, please feel free to reach out to us. And don't forget to follow us on social media and WhatsApp channel for further updates on webinars and events. And I have shared this up. Yes.
Also, Shabnam, I want to add, if like anybody is having any feedback, they can directly contact you and tell the feedback. And also, if they know anything else about any other topic, respiratory medicine topic, they can select and send it to you.
Surely, you can get back to us on either WhatsApp or this.
Yes.
And for any feedbacks, you can get back to us.
Yes, thank you.
Thank you so much, Dr. Sohail, for the session.
Thank you. I'll stop sharing. Okay. Thank you very much.
Yeah, sure. Thank you.